Welcome to another production by the Millennial Mechanical Therapist. Your hosts, Dr. Joseph Gravino and Dr. Clay Case, are two physical therapists trying to treat health issues mechanically. Listen further for patient cases, guest videos, advantages and disadvantages of the way they practice, and much more. Thanks for tuning in today. Check us out on YouTube, Facebook, and at our website. We hope that you learn a lot from watching this video and you come back for more.
Hello everybody, we are the Millennial Mechanical Therapists. My name is Joe.
I'm Clay.
And today we're going to talk, today's part 2, about treatment-based classification, but in particular the research done on clinical prediction rules. So treatment-based classification, we spoke previously in this part 1 about some of the things, how we believe that a good start to TBC or treatment-based classification is housed in having a good foundation of background in mechanical diagnosis and therapy. And that's because typically the first thought process is to get that patient through some sort of repeated movement exam to see if they respond and then move forward. Wonderful. The rest of it, if you've listened to the first one, if you haven't, go back, but we think that the treatment-based classification is a wonderful scheme on how to kind of manage or categorize your clinical reasoning skills, because I think I speak for both of us when I say that's pretty much how we do it as well. And I think many MDT clinicians, without even kind of categorizing in what they do, is very similar to that, where if the patient doesn't respond to repeated movements, they move on to whether manipulations are needed to rule that in and rule out, and then to some sort of stabilization or functional rehab. And the problem is that, there's just the research behind some of these clinical prediction rules that a lot of this stuff tends to be based on isn't necessarily the best. And that's a huge theme in our field in general. But even like the validation studies, and specifically for that done on the Flynn's clinical prediction rule for lumbar manipulation, is that there, specifically, there's almost by chance the person may or may not get better. And I think we at least got to have something better than that. And I think you probably see that in the clinic as well, that if that person truly needs a manipulation, then they should probably get better after 1 or 2 manipulations, right? They shouldn't need multiple manipulations at a time. And by chance kind of makes some sense. Manipulations are a hot topic in both our field and chiros, but if a patient that's all they needed, then I think we wouldn't have a huge category of them. And I know it's a small amount of people who need it, but that's something that we need to look into. Why is it that you can't even validate it in itself that it works in that group, and that even that small group of individuals will get better by chance or by not? So that's something that needs to be addressed. That's something that we should be looking into. Also, a study done by an old professor of ours, Ron Shank, showed, and not a huge study by any means, but a great study, showed that patients who fit Flynn's clinical prediction rule had the same outcomes at 4 weeks as someone who responded to repeated movements. So, that shows, a couple things. What are you doing for that individual if you're just manipulating them, and if they could respond to repeated movements? And should we talk about the ability of patient empowerment and them being the driver of their own therapy versus getting passive treatments like constant manipulations or mobilizations? That could take up so much time on its own. I think we don't need to go into that, but that's an awesome study. That study shows that if they respond to repeated movement stretch preference, there's probably not a need for them to be manipulated, and you're maybe doing them more harm than good by manipulating them if they don't need it. So, these are just some things I think we need to look into, right? And I think goes back to the first video. A proper assessment of repeated movements is probably what is best first, and that's why I think I like the TBC thought process.
Right.
As they go forward, obviously keep validating it, but these are things that we need to think about.
And the same thing goes for stabilization CPRs coming out and things like that. The current one led by Hicks, I think Hicks et al. Kind of developed it. some of the validation studies coming out have even demonstrated that 2 out of their originally proposed tests are enough to validate somebody potentially going to benefit in the short term from a stabilization program. However, when you look at those 2 criteria that were proposed, one was the prone instability test, which I can't say I have any problems with.
Yeah.
Kind of makes sense. But the other is the presence of an aberrant lumbar movement. And anybody who has gone through a repeated movement exam and found a derangement syndrome has probably seen first an aberrant movement pattern, and then second an aberrant movement pattern completely vanish after finding a directional preference and truly reducing the problem going in there. A quick story that I've had, I think you've seen as well, and then another colleague of ours who works within an hour of us has seen. We've had anterior derangements who kind of demonstrate this almost like Gower's sign type situation, where they have to push themselves into extension rather than use an active range of motion sequence to extend from a flex position. After we do flexions in sitting or standing, that just vanishes. Now, if that's not aberrant, I don't know what's aberrant.
Yeah.
But I've had that just go away in about 15 minutes.
So how good is that?
And we kind of get into that situation where if that's one of the 2 that is now proposed to be, they're now proposed to be the validation criteria, how really good are they? So as we go through, the rest of the kind of stabilization situation there, again, in the order, I think it's completely warranted.
Yeah.
If things don't seem to work out with the repeated movement exam, or you don't get centralization, and manipulation doesn't seem to work, stabilization is certainly a beneficial situation. Everybody's going to benefit at some level from exercise.
Yeah.
It's just perhaps putting the cart before the horse as we go might run us into some problems if we fall in love with these CPRs.
Yeah. And I know some of the treatment-based classification school of thought or thought process, he does delineate some of the people that come into your office, and if they seem more symptomatic, then they're most likely going to fall into one. If they're less symptomatic, they're most likely going to fall into the other. At the same time, which I don't disagree with 100%, but I've seen people who are horribly, very symptomatic and respond to either stabilization or repeated movements, and then the same vice versa. Someone who has very little pain, discomfort, and disability do beautifully with repeated movements or stabilization. So I think that's a decent starter, and I think this is what we're kind of getting, is that these just questions need to be brought up, and both by research and by us as we're doing these things and taking note of them with some clinical data and whatnot, so we can add to it. So we went a little bit over, I think, than we wanted to, but if you have any questions, comments, concerns, leave it on Facebook, throw some comments on the website. We'd love to hear what you guys think. If you're using this, what you think, if you're seeing anything different, or if you're hearing anything different coming out new from the newer research, because we all know that takes a while. As we say, always move your patients early,
Move them often,
and move them to end range, my friends, because that's where the magic happens. Until next time, we'll see you then.
see you guys.